Welcome to today's webinar, CROI 2020 Update, Prevention and Epidemiology. I would like to introduce Susan P. Buchbinder, MD, Clinical Professor of Medicine and Epidemiology at the University of California, San Francisco. Welcome, Dr. Buchbinder.
Thanks so much, Jose. I'm really pleased to be here with all of you today. We're going to go ahead and get started. We have a few announcements before we begin. First, if you haven't previously logged into the website, you're going to need to use your email address and reset your password. The IAS-USA designates this live activity for a maximum of 1.25 CME credits. You can also get 1.25 nursing, pharmacotherapy, or pharmacy credits. Now, evaluations are going to be available on your IAS-USA My Activities page by 5 p.m. tomorrow, and then you'll also get information about claiming your continuing education credits. Generous support for this activity has been received from the following contributors. And we're going to be sending you some poll questions. A separate window will pop up that will show the poll questions, and you should choose your answer from the poll questions itself, not in the chat box. But if you've got questions, please do type them into the chat box, and we'll take questions partway through the presentation, as well as at the end. There'll be lots of time for questions. So we'll start with the first poll. From which geographic region are you viewing this webinar? Okay. Let's see if we get the responses shown. I'm not sure if the responses are going to be broadcast or not. I'm not seeing them broadcast, but perhaps they are. Okay, let's go on to the next question. When will the evaluation for this webinar be, which you must complete in order to claim your CME or other credit, be available on the My Activities page in your IAS-USA account? This is just to see if you were paying attention to the original questions, but it's also as a reminder about when you can go and get the evaluation. Great. Okay. So I think that those results have been broadcast, and you got it right by 5 p.m. tomorrow. Okay. Now, please rate your level of experience in the medical management of HIV infection from 1 being a novice to 5 being an expert. And I see it says 1 expert, but 1 is actually novice and 5 is expert. Okay, so we have a range of different levels of expertise, which is great. Now we're not going to be talking about, we're going to be talking more about epidemiology and also about prevention. So no specific expertise is required for this particular presentation. Now, have you accessed any of the resources, electronic posters, webcasts, the abstract ebook, mobile app, or anything else from CROI 2020? You can answer this question. This is the last of these kinds of questions. Okay. Looks like some people have accessed some components of it, but the majority have not accessed resources yet from it. I do want to remind you that you can access all of the materials on the CROI website, and I highly recommend it, particularly if you want to dig into any areas in particular. Okay. So with that, we're going to start. These are my financial disclosures. These are the learning objectives. You should be able to describe trends in mortality and morbidity among people living with HIV, explain the risks and benefits of different PrEP agents, and list potential new drugs to be used for post-exposure prophylaxis. We have 2 pretest questions and 2 post-test questions. So the first pretest question is, what's happening to the gap in morbidity-free years between someone who acquires HIV at age 21 and a person who remains HIV negative? Okay. So we're going to go over the answer to this question as I go through the slides, and I will point out when I'm getting to that question so that you can remember it, because there will be a post-test question at the end of the talk. The next question is, compared with FTC-TDF, which of the following statements about FTC-TAF for PrEP is true? Is it superior in preventing infection, associated with 5 kilogram more weight gain, associated with a 10% improved bone mineral density, associated with approximately 3 milliliter per minute improvement in GFR? Okay. So we have a spread of votes, and again, I will point out when we get to that topic, so it'll be quite clear when you get to the post-test what the answers are. So that begins the introductory remarks. We'll jump in now to the presentation, and I'm going to start with some HIV epidemiology slides, and I culled from the things that I thought might be most interesting to this group. One was about the risk of HIV from blood transfusion post-2015 in the United States. So you'll remember that until 2015, the FDA recommended indefinite deferral of blood donations from all men who have sex with men since 1987. So that was a complete exclusion of men who have sex with men. In 2015, they changed the criteria to allow blood donations after a 12-month deferral from the last MSM contact. So still quite an exclusive criterion, and that's recently changed to 3 months. But what they were doing in this presentation was looking at, was there any change in the incidence of infected units of blood when they changed to allowing a 12-month deferral for MSM. And what they did was they compared the risk of HIV in blood donated from first-time donors that are in this U.S. transfusion transmissible infections monitoring system that accounts for about 60% of the U.S. blood supply. And here's what they found. Prior to the change, the risk from first-time donors is 1 in 3.3 million donations. And after the change, the risk from first-time donors was 1 to every 3 million donations. That's not significantly different. And so what they found was that it was safe to allow the last 12 months. Now, they've now allowed for the last 3 months, as long as a man who has sex with men has not had sexual contact in the last 3 months, they're being allowed, but there's still quite a movement to try to push that even further. But that was good news. We've got a couple of presentations about emergency departments. First is from the LA-USC, which is the largest emergency department in the western U.S. They implemented routine HIV testing of all patients in 2011, and from March 2011 to January 2020, they tested nearly 120,000 patients and found 2.2% were HIV positive. 24% were newly diagnosed positives, and about 3/4 were already known to be HIV positive. But what they wanted to see was how well did they do in linking those individuals to care. And what you can see is that in recent years, the linkage to care of the newly diagnosed, 59% were linked to care, and of those who were previously diagnosed, about half were linked to care. So what this suggests is that we can identify people who are newly diagnosed, and we can also see people who have fallen out of care, particularly in emergency departments, but we need better linkage services because this is, while they linked some number of people to services, that's not good enough, and we need to be able to do better than that. The second presentation from emergency rooms came from California, and there were 4 emergency rooms in San Diego and Oakland. They did over 32,000 HIV tests during an opt-out period, and they used 2 assays, the Architect assay, which they found a false positive rate of 0.1%, and the Roche Alexis assay, in which they found a false positive rate of 0.2%. So given that HIV was not very common in these emergency rooms, the overall positive predictive value of a positive test on the initial screening test, was 75.4%. So there were a number of false screening positive tests that were then found to be false positives when they did the confirmatory test. The people who are more likely to be false positives were female sex, white, and obese. So just as a reminder that it's really important to do these confirmatory tests, you're going to pick up some false positives when you do this kind of screening. Now I have a couple of presentations on STI screening, sexually transmitted infection screening. This one was among PrEP users in Brazil. There were over 400 PrEP users, 96% of whom were men who have sex with men. And what they wanted to do was to see what would have happened had we only tested symptomatic people or had we restricted testing to urine. So what they did was every 6 months they did STI screening that was at 3 sites, pharyngeal, rectal, and urine. And if people came in between, they did and had symptoms, they did do extra screening at those times. But what they found was that most of the STIs were asymptomatic and most of them were rectal. And so if you look at, I'm going to see if I can get this pointer to work, the blue bar, all of the people were asymptomatic at baseline. So if they had only tested people who were symptomatic, they would have missed 100% of the people at baseline testing and 90% of the people at the 12-month follow-up. And if they had only done urine testing, they would have missed 3/4 of the baseline tests if they had only done urine testing, and they would have missed about 2/3 of the tests at the 12-month follow-up. So the bottom line here is that the majority of specimens at baseline and follow-up would have been missed with only symptomatic or urine testing, and it reinforces the importance of 3-site testing in everyone regardless of symptoms, because so much of the STIs in this population of MSM are rectal and are asymptomatic. The second STI-related poster was, I thought, important in looking at how well do we do when we diagnose somebody with an STI in terms of offering them HIV testing and other prevention modalities. This was one in which all patients who had diagnosed gonorrhea, chlamydia, or syphilis who were positive from January to August of 2019 in this New York City hospital had a chart review. So they had 815 unique patients with chart reviews. And what they found was that we do much worse with women than we do with men, although I would say that we're not doing well enough with men either. At the time of the STI diagnosis, women were less likely than men to receive multi-site STI screening, so 0.4% versus 20% in men. So we just learned that we need to be doing multi-site screening for men, and they only did 20% in the men, but they only did 0.4% in the women. Timely STI screening, so if you look here at inadequate, this means that 26% of women and 15% of men had not been tested in the last year at the time that they were diagnosed with an STI and did not have additional testing. And then if you look at PrEP use, PrEP counseling, only 17% of the men were counseled about PrEP, but only 1% of the women. So again, we're not doing well enough even with the men, but we're doing really poorly with women in terms of HIV testing and other kinds of counseling. And so we need to do better with both of those things. When we diagnose STIs, it should be a trigger for us to remember to both do HIV testing and to be doing risk reduction counseling. So there were a number of presentations on people who inject drugs. This was from an excellent plenary session by Stephanie Strasty that I highly recommend and you can get online. But this was showing HIV diagnoses among people who inject drugs, and you can see that there was this 31% decline, but it looked like in the mid-2010s that we were starting to stall out in that group. And then if you look at who are being diagnosed with HIV, it's more increasingly white individuals, people aged 13 to 34, and people outside large central metropolitan areas. So we're seeing more HIV diagnoses in young white rural areas. So that's something for us to pay attention to. Then there was this that came from the New York City HIV Surveillance Registry showing deaths with HIV highest in people who inject drugs. So you can see again that compared with men who have sex with men and heterosexuals, people who inject drugs had a decline in their death rate, in the age-adjusted death rate, but it's still substantially higher than the other populations. And there were 145,000 people with HIV, over 25,000 people who inject drugs. This was really shocking. 9 of 10 decedents who were people who inject drugs were Black or Hispanic. So that's way out of proportion with the size of the population. So you can see that there's this very disproportionate negative impact in Black and Hispanic communities. And independent risk factors for death were people who inject drugs who were 50 to 59 years of age, people who inject drugs who were Hispanic, and those who came from high or very high poverty neighborhoods. Now I'm going to turn to a very interesting study from Kaiser Permanente, and it included data from Kaiser Permanente, Northern California, Southern California, and the Mid-Atlantic states. And this is one of those pretest questions, so I'll point out when we get to the answer that you are supposed to have. So this was a cohort study of adults aged 21 and older with and without HIV during 2000 to 2016. What they did is they frequency matched one HIV positive person for every one HIV positive person. They matched 10 HIV negative people, and they matched based on age, sex, race, ethnicity, medical center, and year. And then they took the clinical data from the electronic health records and internal registries, and they got additional mortality data from state death certificates and the Social Security Administration data sets. And here's what they found. In terms of overall life expectancy, there was a decreasing gap over time. This is the overall life expectancy of a 21-year-old. And the solid line is the solid line is HIV negative individuals, and the dotted line are HIV positive individuals. So that means that an HIV negative individual who is 21 could be expected to live an additional 65 years or live to age 86 by 2014 to 2016, whereas an HIV positive person who was age 21 could be expected to live to age 77. So there's this 9-year gap, but you can see that the gap is narrowing for life expectancy. But when we look at comorbidity-free time, you can see that we're not seeing any lessening in the gap. There's a 16-year gap, and it was a 16-year gap in 2000 to 2003, and it's a 16-year gap in 2014 to 2016, and it's not improving. So somebody who's HIV positive at age 21 can only be expected to live to age 36 before they have a major comorbidity. There's this persistent gap in comorbidity-free life expectancy for liver disease here, 24 years, 17 years for chronic kidney disease, and 16 years for chronic lung disease, and none of those were improving. But if we look at diabetes, we're improving. Now it's just 8 years. Cancer-free time is 9 years. Cardiovascular disease is 8 years. So there was improvement in some, but not all. And overall, there's this 16-year gap with no improvement over time. So one of the things that, this came from Julia Marcus, that she asked was, what happens if somebody initiated ART at a CD4 count of 500? What happened with overall life expectancy there? And there you can see that there's this gain of 11 years, and so there's no longer a gap in overall life expectancy for people who initiated ART at a CD4 count of greater than 500. But you can see that if, in terms of morbidity-free life expectancy, there was no change, even in the individuals who began ART with CD4 counts of greater than 500. So for people who, with HIV who initiated ART with CD4 counts greater than 500, there was improved comorbidity-free life expectancy for cancer and cardiovascular disease, but not for diabetes, liver, kidney, or lung disease. So these were the conclusions. Overall, there's a 9-year gap that remains in life expectancy by HIV status. People with HIV live 16 fewer comorbidity-free years than people without HIV, and this is not improved over time. So remember that for the post-test. People with HIV who initiated ART with a CD4 count of greater than 500 have the same life expectancy as people without HIV, so that's really good news. And again, it emphasizes the importance of starting people immediately on antiretroviral treatment. And for people with HIV who initiated ART with CD4 counts of 500 or greater, the gap in healthy life years is narrower for several, but not all comorbidities. Okay, let's talk about PrEP safety and efficacy. So we have data from the DISCOVER trial of FTAF versus FTDF for PrEP. This was a study done in about 5,000 men who had sex with men and transgender women, although there were less, it was about 1% of the entire population who were transgender women, so it did not really reflect the transgender population well. And these were data from week 48 had been presented at CROI last year. These were data on the 96-week follow-up data. So I'm going to show you both their efficacy results as well as their safety results. Again, just as a reminder, the study was conducted in Europe and North America in cities with high HIV incidence. These are the primary endpoint analysis results for HIV incidence. What you can see is that if you compare week 48 on the left to week 96 on the right, it was essentially unchanged. There was one more in diagnosis in the FTAF arm, so an incidence of 0.16 in the FTAF arm, of 0.3 in the FTDF arm. When you look at the efficacy, the boundary crosses 1, and so the bottom line is that FTAF was non-inferior, so not any worse than, but not superior, not better than FTDF for HIV prevention. I'm going to run you through now some safety-related slides, and what I'm going to show you is that there is not really substantial difference in safety between the two arms of the study. There are some statistically significant differences, but not a lot that was necessarily clearly clinically relevant. So here are bone mineral density, and you can see that there's a 1% increase or a 0.6% increase at the spine and hip respectively in the FTAF arm, compared with a 1.4% drop or a 1% drop in the spine and hip in the FTDF arm. What was important was that there were no fracture events the number of fracture events was equivalent in the two arms, so it was not associated with any increase in the number of fractures. This is data from the renal safety data, and if you look at the estimated GFR, and remember this for your post-test result, there's about a 3 milliliter per minute difference in creatinine clearance, so statistically significant, but not great. In terms of Fanconi syndrome, there was only 1 in the FTDF arm, none in the FTAF arm. So again, minor differences in creatinine clearance. In terms of lipids and glucose, lipids in particular, the FTDF arm here now is the better one, but again, relatively modest differences in total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides, with no difference in the total cholesterol to HDL ratio. And when we look at body weight, which is something that has been of concern because we've seen great increases in FTAF in body weight in people who are being treated for HIV. If we look at prevention, what you can see is that there was a 1.7 per kilogram increase in the FTAF arm compared with a 0.5 kilogram increase in the FTDF arm, so about 1 kilogram difference. So again, not a huge difference between the two arms. So in summary, FTAF was non-inferior to FTDF as PrEP. There was little difference in safety parameters between the two arms, so a little less bone mineral density loss in the FTAF arm, although the differences were modest and there was no difference in fractures. The FTAF arm had a less of a decline, about a 3 milliliter per minute decline, although only 1 case of Fanconi's in the FTDF arm. The FTAF arm had a lesser decline in LDL and HDL, although the total cholesterol to HDL wasn't different between the arms. And again, there was about a 1 kilogram weight difference between the two arms. So some groups are now recommending that you use FTDF as first-line PrEP because it can be used in all populations. FTAF can't be used for people who inject drugs. It hasn't been tested in that population. It also hasn't been tested for people who have receptive vaginal sex. So some groups say, well, why don't we use FTDF as first-line PrEP for all populations and reserve FTAF for men who have sex with men or transgender women who have underlying or predisposing renal or bone abnormalities. This is a study from EPIC New South Wales that studied 5868 participants from March 2016 to April 2018. This was a population-based study in which they were providing PrEP to large numbers of individuals, predominantly men who have sex with men. At baseline, a little more than a quarter had a baseline estimated GFR of 60 to 90 milliliters per minute, so a little bit low, especially since you're not supposed to give FTDF if the GFR is less than 60. They evaluated factors associated with the development of 2 consecutive estimated GFR rates of less than 60, and what they found was that people who started off with a low GFR and people over the age of 40, and particularly over the age of 50, had a much higher rate of having a drop in their GFR such that they would not be eligible to continue on FTDF, but they could continue on FTAF. So what this would suggest is that we may need closer follow-up in individuals who start with a low GFR or individuals 40 years of age or older, or that's a group in whom you might consider to use FTAF. Let's turn to talking a little bit about resistance. So there was resistance that was reported from the DISCOVER trial as well. There were 4 resistant infections in the FTDF arm. All of those individuals were infected at baseline, so it means that they were being treated with inadequate treatment with 2 drugs rather than 3 drugs, and likely developed resistance. There was 1 infection in the FTAF arm, and that individual had low levels of tenofovir diphosphate that indicated that they had poor adherence. All of the cases of resistance had an M184V or I, indicating resistance to FTC. 1 also had a K65R, indicating resistance to a tenofovir-based regimen. And what this reinforces is the importance of baseline screening, close follow-up, and adherence support for individuals who are initiating PrEP. And when possible, to do pooled RNA testing or RNA testing. These were data from a Thai acute infection cohort. What they did is they took 3,400 Thai individuals who were starting on PrEP, and they always did pooled RNA testing, and they found that there were 7 participants who were actually infected at baseline who were antibody negative but PCR positive. What they did is they followed them over time, or they stopped as soon as they noted that the individual was positive. They stopped the PrEP and transferred them over to treatment. But what you can see is that this is what happened with resistance in individuals whose PrEP was stopped within 15 days. So the length of the bar is the number of days that they were on PrEP after the acute HIV infection was detected. And all of them had wild-type virus. Whereas for individuals who went a month or more, 29 days, 35 days, or 122 days before their acute HIV infection was recognized, those individuals all developed resistance with M184I or V mutations. So again, what this suggests is that it's very important to rule out acute infection at baseline because resistance can develop relatively quickly. What the Thai group said is that their way of managing this now is that they put all of the people who they're starting on PrEP onto 3-drug PEP for a month and then switch them after a month to 2-drug PrEP. So that's not something that's being recommended by any of the normative bodies. That's just what they did based on the data that they saw. But again, if you can at least do pooled RNA testing or baseline RNA testing, you can pick up some of these acute infections. And certainly everybody should be screened for acute retroviral symptoms and not started on PrEP if they have any of those symptoms. This was data that was actually concerning from San Francisco, in which they had an individual who had an exposure, started on PrEP, was antibody negative, but found to be positive on a pooled RNA test. They were brought back at 7 days, and at that point had a positive antibody test, but at that point already, and had over 200,000 copies, but at that point also had an M184I. So the baseline genotype was wild type, so the concern was that the person had actually developed resistance very quickly. This is unusual, but it's not obviously not unheard of. And so again, it speaks to the importance of doing, if you can, baseline RNA testing. And these were data from a very interesting study using hair. And what you can do with hair is that because hair grows 1 centimeter every month or so, you can cut hair, and this is the root end, and then march back, this is the root end, and march back month by month and see what level of drug was present in the hair that tells you what was the level of adherence. And you can see that the level of adherence was excellent at in the prior month from this individual, but then declined a bit in earlier times. But based on both timing of the exposures, as well as the fact that the person had symptoms and a viral load of 3.1 million, they believe that the person was infected during a period of time with very high levels of adherence and probably infected with a resistant virus, which has been reported now in 5 or 6 cases that have been well documented to be high levels of adherence. This person had an M184V and a K70N. And so what we know is that PrEP is not 100% protective, but it's very highly protective, over 99%. But there are these rare cases that have been documented that with even high levels of adherence, particularly if the person was exposed to resistant virus, they may have breakthrough infection. Let's see, we've got lower tenofovir levels in DBS during pregnancy. So I've got a couple of pregnancy-related presentations to show you. The risk of HIV infection is doubled in pregnant and postpartum women in sub-Saharan Africa, which makes them a prime population for PrEP. But we also know that pregnancy causes physiologic changes expected to reduce the levels of tenofovir in DBS. So there's, because there's increased renal clearance and there's also hemodilution. So the question was, what are the levels of tenofovir that we might see in pregnant women compared with postpartum women? So they took 20 pregnant women and 20 postpartum women, each of whom were given 12 weeks of FTDF PrEP under direct observation. And here's what they found. The tenofovir levels, the phosphate levels, were 31 to 37% lower in pregnant women than in postpartum women. So what this reinforces is the importance of strict adherence to PrEP during pregnancy. It's not, at this point, recommended that there be different dosing in pregnancy, but it is very important that women who are pregnant take a daily pill with tenofovir diphosphate. I'm sorry, with tenofovir disoproxil fumarate FTC, TDF-FTC. This was good news on birth outcomes in women on PrEP during pregnancy. And what you can see is that for all of these pregnancy outcomes, miscarriage, stillbirth, preterm birth, congenital malformations, low birth weight, and small for gestational age, there was no significant difference between, on the left are the PrEP unexposed, and on the right are the PrEP exposed. The only difference was in preterm birth, where there was a slightly higher rate of preterm birth in the PrEP unexposed group compared to the PrEP exposed group, with a p-value of 0.01. So PrEP appears to be quite safe for pregnant women, and again, because pregnant women have a much higher rate of risk of HIV acquisition in these settings, in sub-Saharan Africa and in settings in which women may be exposed to HIV, it's important to counsel about PrEP and to be sure that PrEP adherence is high. Let's go to PrEP uptake, adherence, persistence, and impact. We're going to come to the questions at the end, but keep the questions coming and I will get back to them. So I've got a number of interesting ways of delivering PrEP, this was one that I found most interesting. This was using a mobile van for HIV and STI testing and PrEP services. Presumably you could also deliver PrEP using social distancing if you've got a large enough van. But this was 429 people seen from September 2018 to September 2019. 62% of them wanted PrEP, and of these, 82% were Latino, 7% were Black, 95% filled their prescription, and 74% completed a follow-up visit. So these are very high rates of both filling and following up on PrEP, and it does look like a promising strategy for delivery of services to underserved populations. So I thought that was an interesting poster. One of the questions that arises is why are the rates of PrEP use in the South so much lower? And it's undoubtedly multifactorial, but this was an interesting poster that looked at prior authorizations and whether or not they're required for FTDF PrEP. And in this study, qualified health plans in the South were 16 times more likely to require prior authorizations as in the Northeast, 16 times higher. And after you adjusted for the plan type, these qualified health plans in the South were 30 times as likely to require prior authorization. So that's putting barriers in the way of getting PrEP to the communities that need them most, given that the South has the highest rates of HIV infection and the lowest rates of PrEP uptake. This is an area for potential intervention, a systemic change that could make a difference. These were data from Seattle looking at knowledge, interest, and use in PrEP. And what they did is they took data from an online survey as well as Seattle Pride that was administered from 2017 to 2019. And they graphed that on this chart. What they did is they looked only at the subgroup of men who have sex with men who they considered to be at high risk, which meant that they either had a bacterial STI, meth or popper use, 10 or more male anal sex partners, condomless anal sex with an HIV positive or unknown partner. And then from 2017 to 2019, what they saw was that awareness of PrEP, shown up here, actually improved from 84 to 96%. So PrEP awareness is very high among this group of high-risk men who have sex with men in Seattle. Their interest in PrEP remains stable over time at about 2/3 of individuals. But using PrEP increased from 33% to anywhere from 43 to 46%, which was great news. Their target is by 2020 they wanted 50% of men who have sex with men who are eligible for PrEP to be on PrEP, and so they're approaching that that rate, which is great news. These were data from Northern California, Kaiser, in which they looked at 8840 participants, patients, who they did this testing algorithm and tried to figure out who was at very high risk for HIV acquisition, which meant that they had 1% or greater risk of HIV within 3 years. What they found was that the people overall, only 40% of people who were at high risk were using PrEP, but it was lower in 18 to 29-year-olds and the over 70-year group. It was much lower in women. It was much lower in Black patients, and there was this sort of linear relationship with lower SES, where it was lower the lower the SES was. So again, we need to understand why the rates are so low in women and in Black patients, and I think there's some hypotheses about why it might be lower for lower SES groups in terms of cost of medication. But this is a closed network where everyone should have access to care. So this is not just an access to care issue. We have to look at how well we're doing at counseling and providing PrEP prescriptions, as well as what the barriers are to uptake of PrEP. These were data from the Thrive demonstration project in 7 U.S. health departments. And what you can see is this cascade of screened to eligible to referred for PrEP to linked to PrEP to prescribed PrEP. And this is just among MSM of color shown on the left and transgender women of color shown on the right. And you can see that at each stage of this cascade, transgender women are at lower, have a lower proportion who made it to the next step. And then in a multivariable model where they looked at men who have sex with men of color compared with white men who have sex with men, the MSM of color were equally likely to be referred and linked to PrEP, but less likely than the white men to be prescribed PrEP. So again, it looks at what we're doing as providers to get PrEP to communities that may really need PrEP, and why we're continuing to see these health disparities. These are data on PrEP uptake and adherence in transgender women. So we have a couple of presentations on transgender women. This was estimated HIV prevalence in transgender women. The background was just that the estimated HIV prevalence in transgender women is about 28%, so the PrEP need is high. And in this LIGHT study, in 751 transgender women in 6 cities, 39% had a PrEP indication. But you can see that among the group that had a PrEP indication, as you go across this PrEP cascade, only 23% were currently using PrEP and only 14% were adherent. So PrEP uptake was very low in this group, and that's despite 74% being having health insurance. So again, understanding why we have this drop-off in the cascade is quite important. Oh, I think I skipped one. No. Okay. This is PrEP use in cisgender women in Los Angeles, and the CDC estimates that approximately 500,000 cisgender women may be eligible for PrEP. This is the first demonstration project for cisgender women. There were 136 women enrolled, and they were followed for 48 weeks and given FTDF. By 48 weeks, 39% had discontinued PrEP, and only 18% had dry blood spots consistent with 6 to 7 pills a week, which is what's recommended for women. So that's, you can see it started off at about 40% and it's diminished over time. The main reason for discontinuing PrEP was concern about side effects and long-term effects. So that's very important because those are things that we can intervene on. Side effects generally go away over time if you can stick it out for that first couple of weeks. And long-term effects hopefully should not be a great concern because PrEP has been shown to be very safe over a longer period of time. So if we can address these issues, perhaps we can get cisgender women who need PrEP onto PrEP, but it's likely that we need additional interventions to support PrEP use in women. These were some data on PrEP persistence and adherence in men who have sex with men in 4 U.S. cities, and they took the National HIV Behavioral Surveillance survey in 4 U.S. cities in men who have sex with men, and they measured persistence as people being still on PrEP and adherence as being how much PrEP was being used. So they said, okay, did you take any PrEP in the last 12 months? And 80% of the people who said that they had taken PrEP in the last 12 months still had any drug detectable. So about 80% were still on PrEP if they had started sometime in the last 12 months. They were less likely to be on PrEP if they were 30 years of age or less than 30 years of age, less than a college education, publicly insured, or had fewer than 10 sex partners. And then they said, okay, if you had PrEP on board, how many had levels consistent with at least 4 pills a week? And that was another 80%. So again, less likely to be adherent if you were under 40, if you were black, if you had less than a high school education, or if you lived in Philadelphia as the city. So these are actually better numbers than what we've seen in many other populations. So 80% stayed on PrEP, and of those, 80% had levels consistent with 4 pills or more a week. These are data looking, again, at going back to Seattle. They took people who were diagnosed with an STI, so men who have sex with men and transgender individuals who have sex with men, and they asked them about PrEP use. And then they followed them forward over time to see what was the rate of HIV infection. And what you can see is that the risk of HIV infection in the people who were not on PrEP was pretty high. It was 1.86 cases per 100 person years, so about little less than 2% per year became infected, compared with 0.17 cases per 100 person years. So that represents an 84% reduction in HIV infection rates in PrEP users compared with non-PrEP users. So that's, again, very good and in keeping with what we've seen in other studies, but this is in real-world setting. All 5 of the PrEP users who became infected had stopped PrEP use. So these were not breakthrough infections. These were failures because people had stopped taking PrEP. I do want to comment on one of the comments that came from Jim Pickett. Jim, thank you. Condom with anal sex with an HIV-positive person isn't always considered risky. That's a very important point to make. If the person is fully virally suppressed, then the risk is essentially 0. So that's quite an important point to make, so thank you for pointing that out. Non-daily PrEP use in a national survey. So I wanted to just show you a couple of presentations at the end of this section on non-daily PrEP use, because we know that 211 PrEP is also highly effective for men who have sex with men. So these were data that came from sex networking sites for men who have sex with men. It was a national survey of nearly 10,000 participants. 61% said they were interested in non-daily PrEP use. So non-daily PrEP use is of great interest, but only 5% were using non-daily PrEP. But I'm going to show you what kinds of regimens people were using, because some of them have not been evaluated. And so we want to be sure that people know about the kinds of measures that people can take that are that should be protective, and differentiate those from just taking pills not on a daily time period. So only around the time of sex, 211 and 1 pill. 211 PrEP works, we know. 1 pill 1 day before and 1 pill the day after sex, and 1 pill just the day of sex may not be sufficient. So we do want to let people know about 211 PrEP. On a regular schedule, but not daily, so some people take it on T's and S's. That's Tuesdays, Thursdays, Saturdays, and Sundays. That's 4 days a week. That should be equivalent for men who have sex with men to 7 days a week, so that should be fine. Every other day should be fine, but Fridays and Saturdays may not be sufficient. Only a few weeks at a time. That makes sense when people are going on vacation, if that's when they're most sexually active and maybe in greatest need of PrEP. And other non-daily regimens, daily when expecting sexual activity, otherwise every other day, that makes perfect sense. Whenever I remember is probably not adequate for maximal effectiveness. So, but if we look at the reasons for non-daily PrEP use, infrequent sex was the most common. That makes perfect sense. Concerns about cost. We would hope that people don't need to go on to less than daily PrEP if they want daily PrEP, just because of cost. Concern about long-term side effects, not having sex perceived as high risk. Those are also other reasons why people were using non-daily PrEP. And then this was data from 211 PrEP users at Kaiser, and what you can see is that at 3-month follow-up, 51% were still using 211, 19% had switched to daily PrEP, 15% had a combination of 211 and daily PrEP, and 10% had stopped PrEP. And you can see that the motivations for using 211 PrEP, the majority of those were because of infrequent sex, which again makes sense, and the reported challenges were very low. This is 6% dosing or adherence, 5% had trouble planning sex in advance, only 3% said that they had side effects. So we do want to get 2-on-1 PrEP and other regimens into the consciousness of individuals who are men who have sex with men, because it may make most sense for them, whatever is going to work for individuals. I'm going to close by talking about some post-exposure prophylaxis non-human primate challenge studies, and then I'm going to go to questions. So hang tight, I will get to your questions. This was data from Marty Markowitz talking about islatravir, and what he started off by just pointing out is that we've got pre-exposure prophylaxis that's good for all populations. FTC-TDF is the current standard of care, and FTAP is good for men who have sex with men and maybe for transgender women. We have on-demand PrEP for men who have sex with men only. And then we have post-exposure prophylaxis. The problem with post-exposure prophylaxis is that generally it's recommended that you take it for a month, and it has to be initiated within 72 hours following exposure. So what the next 3 presentations I'm going to show you were focused on is there another way to administer PEP, post-exposure prophylaxis, that doesn't require that 30-day period of time. And what Marty presented was on weekly oral islatravir protection against IV challenge. So islatravir is an investigational agent. It is the first-in-class nucleoside reverse transcriptase translocation inhibitor that has multiple mechanisms of action. It is noted for its very, very high potency. It has an excellent resistance profile in that individuals who have nucleoside resistance are still sensitive to islatravir. It's got excellent safety and tolerability. It has a very long half-life, and it has favorable tissue distribution. And these were older data that, just to put this in context, that islatravir may be able to be used as pre-exposure prophylaxis. These were data from a low-dose rectal challenge model in macaques, in which giving weekly islatravir was fully protective against rectal challenge. What Marty showed in this presentation was that if you gave weekly islatravir starting 24 hours after challenge, after IV challenge, with 4 doses a week, or then they backed off to 3 doses, four weekly doses, then they backed off to 3 weekly doses, then they backed off to just 2 weekly doses. 6 out of 6 animals were infected, and 6 out of 6 untreated controls became infected. 6 out of 6 treated animals were protected, whether they had 4, 3, or 2 weekly doses. When they did 1 weekly dose, unfortunately 2 of the 6 were infected. But when they mapped the PK data from humans, a single oral dose of humans, it was higher than what was seen in the 2 weekly doses of islatravir in the non-human primate study. And so what they concluded was that as few as 2 weekly oral doses of islatravir, 3.9 milligrams per kilogram, given 24 hours after an SIV MAC 251 IV challenge, completely prevented infection of rhesus macaques. A single islatravir dose 24 hours after challenge prevented infection in 4 of 6 monkeys. Extrapolation to human PK data suggests that a single oral dose given within 24 hours of HIV exposure in humans could provide effective PEP, and that would really be a game changer if you could just take 1 pill within 24 hours after an exposure, and that was good enough PEP. So the results support the potential utility of islatravir as a simplified PEP agent in humans, although the feasibility of clinical trials to test this is challenging. These were data from another non-human primate challenge model. This is now vaginal inserts that were given to using tenofovir alafenamide with elvitegravir. And the insert was inserted 4 hours after challenge, a single insert, and there was 100% protection in this non-human primate study. So again, another option potentially for PrEP would be development of elvitegravir, tenofovir elafenamide as a vaginal insert. These were data from Buchbinder with FTC TAF as PEP. This was a SHIV low-dose rectal challenge study. They saw only partial protection in these models, and they looked at what happened with different dosing schedules. The one that worked best was 12 hours afterwards, and then a second dose 36 hours afterwards. They didn't see complete protection, but they did see 82% protection overall. It was better than when they looked at FTC TAF alone, but we wouldn't give a true drug regimen right now as PEP anyway. But what you need to know is that in this case, they went up to a double dose of Buchbinder to what is given in humans. So, and then finally, we'll close with one clinical trial of Buchbinder FTC TAF as post-exposure prophylaxis for 28 days. This was 48 people initiated PEP within 72 hours after sexual exposure. The most common side effects were nausea, vomiting, fatigue, and diarrhea. All of the symptoms were grade 1 except for one case of grade 2 fatigue that led to discontinuation. 2 patients had elevated transaminase levels, one with the reduced creatinine clearance, but all of them resolved after the PEP was complete. And the bottom line was that this Buchbinder-based regimen was better tolerated than older regimens. So that's good news for PEP, but I think it's exciting to look at the potential for new formulations that wouldn't require a full month's worth of drug after an exposure. So I'm going to close with these 2 questions, and then we'll take questions from you. What's happening to the gap in morbidity-free years between someone who acquires HIV at age 21 and a person who remains HIV negative? Remember, this is morbidity-free years. Great. Okay, so 2/3 of you got that right. There's a gap of 16 years and there's no narrowing of the gap. Okay, and the next question is, compared with FTC TDF, which of the following statements about PAF for PrEP is true? Okay, so more than 4/5 of you got that one right. It's associated with approximately a 3 milliliter a minute improvement in eGFR. So not much difference in terms of safety profiles between FTAF and FTDF. Okay, so let's turn to answering some questions. There was a question regarding pregnant and postpartum women. Are there other ARVs besides TDF reduced compared to other women? This was a study just on pre-exposure prophylaxis, and so they only were looking at TDF levels. There are data, I don't have those here, on pregnancy in other women. There's a question about, is Buchbinder used yet for PEP? Yes, it is, orally, and it can be used. It's a licensed drug, and it should be equally effective to other 3-drug regimens. So that's BIC, TAF, FTC. So that you should be able to use that. I was asked what's your stance on recommending condoms in PrEP for certain patients? I think if you, that people should be counseled about STIs. So condoms aren't needed for PrEP. PrEP is very highly effective in terms of prevention of HIV infection. But if you want to be preventing STI acquisition, then condoms are important to be used. So I think it's worth a conversation with individuals about the fact that PrEP is not going to protect against other STIs. But I think that if you're looking for HIV protection, PrEP is enough. There's a question about, is there data on people who initiated ART with less than 500 CD4 count? And I think that that goes back to the morbidity and mortality-free period of time. And what was seen in that case was that there was a complete reduction. There was no more gap left in mortality if people started people started treatment at the time that their CD4 count was over 500, was 500 or greater. But in terms of morbidity, for some of the morbidity there was an improvement, but for most of them there was not improvement seen. So there was still a gap seen even if they started PrEP at an earlier time, started treatment at an earlier time point. So that's quite important. There's a question about how they defined linkage to care from, I think that's from the emergency department study, and I believe that that was just having a single follow-up visit was the definition for it. There's a question about how would we do a PEP clinical trial, and I think that's really an excellent question because the risk of HIV acquisition after a single exposure is quite low. So I think one potential way of doing a PEP clinical trial would be in higher risk exposures like parenteral exposures or needle sticks. So you could do a healthcare worker study that doesn't tell you much about sexual acquisition, but it would tell you about, and that may be why they did the IV challenge in the islatravir study. But I think that it is challenging. You probably have to have a very, very large study to be able to do a PEP study, even without a control condition. And I don't think you could have, your control condition would have to be some other active agent. You couldn't use a placebo control. So I think if you were trying to do a non-inferiority trial of PEP, it's going to be just astronomically large and very difficult to try to figure out how to do. So I think, I don't know, I think that's one of the things that was raised in that presentation is why that might be quite difficult. There's a question about what's the average or typical rate of PEP uptake post-exposure. I didn't see, that wasn't presented at the meeting, and I don't know how common it is. I think we don't do a very good job of actually counseling people about post-exposure prophylaxis. We need to do a better job of that because we do want to give people that option. We do believe that it's highly effective, and it's important for people to know about PEP and have access to PEP. There was a question about, in the PrEP and cisgender women study, what was the HIV vulnerability profile of the participants? Unfortunately, I don't have those data on hand, but if you go to the website, you can actually look up the poster itself and see what the risk profile was. I don't believe that they presented data on risk perceptions, and I think that's very important. And I think the other thing is sometimes moving away from just risk perception to looking at PrEP. There was a poster in men who have sex with men, but looking at, or actually it may have been in women, that Sarit Golub did. So you could look up Golub in the electronic materials, and you could find her abstract. And I think PrEP efficacy is self-efficacy is very important, but also being less concerned about having this reduced fear of having sex is also quite important. So sometimes moving away from just a focus on people's risk perception to giving them comfort in their sexual practices can be a good motivator. There's a question about would we recommend PrEP to a partner who is when a person is an elite controller. If somebody's an elite controller and they've got an undetectable viral load, then their partner doesn't need PrEP because there's no risk of transmission to that individual. So we believe that should be the same whether they're an elite controller and are able to have an undetectable viral load without use of antiretrovirals or because of antiretrovirals. So the good news is that it appears that that undetectable is untransmittable, and so it's even more effective than PrEP because it's 100% as opposed to 99%. Someone asked, was there information on strategies people are using to keep track of their PrEP 211 schedule? And there was not data presented, but there is a lot of innovation happening right now that's quite important in trying to support people in taking their 211 PrEP, because it can be more complex than just taking a pill a day. So that may be one of the reasons that people go from taking 211 PrEP to going back to taking daily PrEP, because it can just be easier to manage that way. But there are a number of innovations that are in development. I didn't see any of them presented, though, at the meeting. There was a question about it. Does co-infection with COVID-19 have an impact on the patients on PrEP? Not that we would be aware of, not that we should anticipate. There is this question going on right now about whether or not tenofovir-based regimens or Truvada in particular might have any protective effect on COVID-19. And there's a European randomized controlled trial, I believe, that's testing that hypothesis, but no data on that. Some elite controllers can have blips that get into the 3 log range, which could be transmissible, so that was a follow-up. While the risk is low, it would not be 0. So I think what we're talking about is if you're undetectable, you're untransmittable. If you're having a lot of blips, then we don't know if you're transmittable or not. So somebody who's fully virally suppressed, whether it's with treatment or because they're an elite controller, should not be transmissible. What's the evidence and current expectations for ED PrEP in women? And so I don't know if that means emergency department PrEP or if that's standing for something else. But the expectations, I mean, we should be counseling women much more aggressively than we are now about PrEP. And any woman who gets diagnosed with an STI should at least be informed about PrEP and offered PrEP as a potential tool to help them be protected against HIV acquisition. So as well as people who are in discordant relationships where if they're in a serodifferent relationship, their partner is positive and not fully virally suppressed, or if they have concerns about their partner's potential levels of exposure, or if they just have concerns that any of their partners may be HIV infected, they should at least have an opportunity to talk about the option of using PrEP. And we're just not getting PrEP to women. So then there was a comment, why wouldn't you refer the partner of an elite controller for PrEP? If you don't, that's an assumption that the relationship is strictly monogamous. And that's absolutely the case. So I was jumping to the question of, is the person at risk from their elite controller partner? Anyone who comes to you should be counseled based on let's talk about all of your partners, and it shouldn't be assumed that somebody is in a mutually monogamous relationship, or I think the term monogamy is not particularly helpful because people can use the term monogamy to talk about an emotional monogamy that doesn't necessarily mean physical monogamy with other people. So it's really a question about, do you have any partners who could potentially transmit HIV? Now, there are people who say, I only have sex with partners who are HIV positive and fully virally suppressed, or other people who are on PrEP. And in that situation, I would still counsel the person to consider PrEP for themselves, just because if they have multiple partners and they're assuming that their partners are taking PrEP on a regular basis, that may be, it may be good enough, but it may not be good enough, and why not protect yourself in that situation? But again, if somebody is in a relationship with someone who's known to be fully virally suppressed, then they don't need protection in that situation. But if they're relying on a lot of partners who are using PrEP, may or may not be using PrEP, I just think that you can get another, you can be in control of your protection by being on PrEP yourself. How can we better counsel pregnant and postpartum women about their increased risk of acquiring HIV? Do we know the biology behind this increased risk? We don't completely know the biology behind the risk. There are lots of hormonal changes and changes to the mucosa and the mucosal environment during pregnancy and in the postpartum period. And in some very well-detailed studies out of Africa, women who were pregnant and postpartum, after adjusting for how much sex they were having, were at substantially increased risk of HIV acquisition. So it is important for us to counsel pregnant and postpartum women about the potential for increased risk. And then if using PrEP, in particular, women during pregnancy may have lower levels of tenofovir, so that's quite important